current thinking about how we ventilate in preterm babies with RDS and BPD, and from there, talk about several potential strategies that we might be using or we may be able to use for babies with evolving BPD. Now, some of these strategies are widely used. Some of them are less frequently talked at the current time. As you all know, BPD mostly happens in extremely preterm infants. These infants are born with very immature lungs at the late canalicular phase or saccular phase of their lung development. They present with RDS at birth that may require high-rate ventilator support. And then while growing in their lungs in our NICU, lung injury is common from high oxygen exposure, mechanical ventilation, infection, or other reasons. Oops, kind of got out of my big screen. Okay. And weeks to months later, infants with delayed alveoli growth and also abnormal injury repair would end up with established BPD. So we need to remember the time frame we're talking about evolving from RDS to BPD to the established BPD are weeks to months, right? It does not happen overnight. Therefore, when we talk about it, we talk a lot about different mechanisms. In the early postnatal days, the biological features of a preterm infant decide that the safe window of ventilation is pretty narrow. And you can see in this figure, both volume trauma and atelectal trauma can easily occur in these infants. Therefore, in our Neonatology Society, the main focus of early postnatal respiratory support has been how to avoid lung injury while we provide respiratory support for these infants. Although it's important to remember to provide adequate support, protective ventilation for infants with RDS has been emphasized a lot, so that positive pressure ventilation-induced lung injury is minimized. So when you look at literatures, there's so much about early postnatal days, how we want to minimize lung injury, right? But before we discuss ventilations for evolving BPD, I think we need to first understand how we ventilate infants with RDS and establish BPD. Let's spend some time to review the lung mechanics and ventilatory strategy for RDS first. The RDS lungs usually start with uniform lung disease, like in this picture, right? And the lung mechanics is similar throughout the lung fields. This type of lung can be considered as having one compartment. So when we talk about BPD ventilation models, we talk about one compartment model versus two compartment models. And an RDS lung in early postnatal time, it's usually a uniform lung disease with similar lung mechanics, and we consider that as a one compartment model. With surfactant deficiency and lung compliance is significantly decreased in infants with RDS. And as a result, elastance is greatly increased. This means the babies would have very stiff lungs, very stiff alveoli that are difficult to inflate, but very easily to collapse. These babies, therefore, would need a certain degree of positive pressure support to maintain alveoli recruitment. However, the airway resistance is generally normal at birth. And with that comes with the concept of time constants, right? Time constants is the airway resistance times compliance. this is a very important concept for BPD ventilation, and we will mention that again in the later time of this talk. We all know we generally need 3 to 5 time constant to get our alveoli sufficiently inflated during inspiration. And similarly, we need 3 to 5 time constants for them to empty out during expiration. With short time constants, short inspiration time will be sufficient to fill the RDS lungs. And similarly, short expiration time is adequate to get these alveoli empty out. Corresponding to this pathophysiology and lung mechanics, we generally take a ventilator strategy of a fast rate, short inspiration time, with sufficient targeted tidal volume and expiratory pressure. However, over the weeks to months of the stay in the NICU, the premature lungs changes over time. Presently, the pathophysiology of BPD in the very preterm infants is thought to be the simultaneous clash of programs for lung development, lung injury, and also lung injury repair over the weeks to months required to care for these infants. Therefore, despite similar clinical presentations, the pathophysiology of the severe BPD kids can be very different, depending on the timing and combinations of exposures. For example, although both can be diagnosed with severe BPD, the lung pathophysiology is very different in a 4-month-old baby born at 25 weeks gestation who had early onset sepsis and required mechanical ventilation since birth, as compared to another 4-month-old baby also born at 25 weeks of gestation, but had been on non-invasive support until intubated at 34 weeks for NEC. All right, so these two babies can all be diagnosed with severe BPD, but their lungs are different. The pathophysiology is different, and their lung mechanics is going to be different. Despite early surfactant replacement and lung protective ventilation, many extreme preterm infants would require prolonged mechanical ventilation or high level of non-invasive support. Over time, the lung mechanics would change from those of a typical early stage RDS lung to unevenly ventilated lungs with increased dead space, high airway resistance, and variable compliance. However, ventilation in the lungs of the BPD infants may still be relatively even in some patients with established BPD. This is mainly seen in patients with typical new BPD, who did not require too much of high-level respiratory support in the early days of their life, but still went on to have significant delay in alveolization. And they gradually require more respiratory support when they become bigger and with more requirement in terms of activity. Similar to RDS babies, chest X-ray in these babies often shows more generalized haziness. The lung disease is more homogeneous, and we therefore can describe these lungs also as a one compartment model, as we have talked about in the RDS lungs. The chest X-ray in the middle of this slide came from one of my patients from CHOP, who was born at 30 weeks gestation, but had PPROM at 23 weeks. He had gradually increased respiratory support needs and eventually needed to be intubated before transferring to CHOP at around 39 weeks of postmenstrual age, mainly because he was not growing and he could not wean off high level of non-invasive support and was struggling to breathe. His lung biopsy, because he was born at 30 weeks, we were puzzled a little bit whether this is a typical BPD or not. So we actually got a lung biopsy, and his lung biopsy showed very uniform alveolar simplification. So in the baby, in a BPD infant with a more homogeneous lung disease, we can use both SMV, PSV mode, or AC mode. Those are common modes that we use for RDS. And those RDS, the ventilator strategies may be similar to an RDS baby. However, because of the change in lung mechanics that we have talked previously, these babies may need a larger tidal volume and a longer I time. Not extremely long, but maybe a slightly longer I time compared to the RDS babies that because of the change in the pathophysiology and the lung mechanics. Unfortunately, most of the infants with severe BPD doesn't have this uniformed lung disease type of picture. And what we end up is this, what we call a two-compartment model. They have very different lung pathophysiology. The lung mechanics of those lungs with heterogeneous lung disease is best described by this two-compartment model. In reality, they probably had many compartments, but we have to simplify them in some way. So we kind of simplified it in a two-compartment model. In this type of lung disease, there are regions, as we have seen in those homogeneous lung disease or RDS babies. So the compliance and resistance are relatively okay. The time constant is short. And in this areas, very similar to the RDS lungs, air can quickly get in and get out of these regions. However, this type of regions are usually not the dominant regions. Most of the regions in the severe BPD baby's lungs are the ones that are very different. So what we call them slow compartment or slow unit. They would have high airway resistance, but the compliance in these areas may be variable. It can be normal or high. But in the end, because of the significantly increased in lung in the airway resistance and the overall decreased overall variable lung compliance, most of the time they end up with very long time constant in the slow compartment. And unfortunately, these babies, this type of lungs areas may be the dominant areas, maybe the majority of the regions. So because of this heterogeneity, ventilator management is difficult in the lung protective strategies we just described in the RDS lungs, and we'll talk about it a little more later. The significant uneven ventilation would also cause VQ mismatch in different areas of the lungs. This chest X-ray belongs to an infant with severe BPD I consulted earlier this year. The right lower lobe is collapsed, which will result in intrapulmonary right to left shunting. Although better aerated in the right upper lobe, it still has a fair amount of atelectasis. The left upper lobe, it's a little bit better, a little bit more open, but not, of course, not a normal lung at all. And then the left lower, it's significantly more hyperinflated. And in this area, then you would have increased dead space. So you can see in this picture that in this baby's lungs, different area would have different type of VQ match. Some are better, some are more right to left shunting, some of them are more increased dead space. Unfortunately, the protective ventilation strategy we used in RDS with small tidal volume, fast rate, and short I time will not be able to address the ventilation needs of the slow compartment of the BPD lung. Therefore, continued use of this type of ventilation strategy often results in worsening VQ mismatch, air hunger, air trapping in the BPD infants with a heterogeneous lung disease. And this is a problem I often see when I see patients in China and also sometimes in Philadelphia, in the patients in America. People think about, oh, this baby has BPD and I need to use a longer longer I time. So they put the I time higher, but at the same time, the baby is not ventilating well and they keep on increasing the rate. So then you end up with a fast rate and a high inspiration time, and this baby will get more air trapping over time, and they become more and more uncomfortable. So consider their lung pathophysiology with areas of air trapping, segmental atelectasis, and often airway malacia. These babies with these heterogeneous lung disease or two-compartment model have much higher airway resistance and variable lung compliance, and would need a much larger tidal volume, much longer I time, but at the same time, much longer E time to really get the air in and out from different regions of their lung. They also require significantly higher PEEP and adequate pressure support to promote even ventilation in both the fast and slow units of their lungs. All right, we talked about RDS lungs and how we ventilate them. We talk about BPD lungs with one or two compartment model and how we think we should ventilate them. How about the kids in between? From an RDS lung in a few days after birth, all the way to the established severe BPD weeks later or months later, the baby's lungs undergo gradually changing pulmonary mechanics and also pathophysiology. These infants with evolving BPD has passed the initial RDS period, but not yet has established BPD. Their lung parenchymal disease and lung vascular development are delayed, and they have varying degrees of lung injury. Like I gave you the example of the two babies in the early slides, both born at 25 weeks, but their lung injury can be very different. At the same time, the pulmonary mechanics of these infants are constantly changing from RDS in the early phase towards BPD over the time. Then what strategy can we use to prevent the involvement of severe heterogeneous lung disease? Unfortunately, there are not many good clinical research data that can be used in our practice. With limited time, I would discuss several potential strategies. Some are already widely used, and some are mentioned less frequently. The first one I want to talk about is permissive hypercarbia. This has been on the main stage of neonatal ventilation for many years. I think as long as I can remember being trained as a neonatologist, this has been mentioned. But however, there have been only limited data for mild hypercarbia in the low 50 range, the PCO2 in the low 50 ranges of a preterm infant in the early postnatal days. When you really search literature, that's what I can find. But yet we all extrapolate those data into ventilation management of all units, regardless of their gestational age, their weight, and their disease process. But is permissive hypercarbia really safe and beneficial for BPD prevention? There are several theoretical benefits of permissive hypercarbia. For example, it can help avoid hypocarbia and its related complications. So we don't like their CO2 in the 20s all the time, and it has multiple downsides of ventilating a baby like that. And also, by allowing a higher target of PCO2, it may help decrease the level of mechanical ventilation and allow early extubation, and thus avoid ventilator-associated lung injury. In addition, decreased level of ventilation potentially may dampen the systemic pro-inflammatory response, and mild hypercarbia may increase oxygen delivery to tissues and also cerebral blood flow, preventing cerebral ischemia. These are some theoretical benefits, and some are supported by some animal data. However, although permissive hypercarbia is theoretically plausible, the current evidence questions that it is safe and efficacious in reducing the risk of BPD. This table summarizes the main findings of several important studies. As you can see, none has demonstrated obvious benefits in preventing BPD, but raised more safety concerns. In addition, the timing and range of PCO2 that may provide benefit without increasing the adverse outcomes are not known. We don't know how high we can go and when we can go that high. We therefore really caution the overly zealous use of permissive hypercarbia because this benefit is not really demonstrated and the safety profile is not totally established. And because of this widely used concept of permissive hypercarbia, and also in the recent years talk about how bad mechanical ventilations and mechanically ventilation-related lung injury. In addition, our non-invasive support has been really advancing rapidly. It can support a lot of babies without needing to intubate them. And this has been widely accepted. But now we are seeing a phenomenon, both in China and in the US, that people are trying to extubating the babies with all cost and allowing higher and higher PCO2s. Here I gave you two examples of my patients from CHOP. Both actually died from severe lung disease and especially very, very severe pulmonary hypertension. The first baby actually received 42 days of dexamethasone to help extubate him and also help him to keep extubated. But he was not growing and he was not doing well. And then he got a viral infection and actually wound up on ECMO for us. And even after taking him off ECMO, we could not get him better in terms of his pulmonary hypertension, and he died. And the second baby on the right is a baby that not intubated for a very long time, but received 5 months of non-invasive support. And the outside hospital was allowing her PCO2 to raise to 80 to 120 range. And before she was transferred to us, she was on very high level of NIPPV support with 100% oxygen, SATs in the 70s, with heart rate in the 200 range. And the outside hospital refused to intubate this baby because they tell us intubation is evil. And you can see the growth curve of this baby. She was born relatively AGA, but she was severely growth retarded by the time she came to CHOP. And she too eventually died of severe pulmonary hypertension. I don't think she has enough of the lungs and enough of the lung vasculature at all. And this baby, again, received multiple courses of steroids. All right, that's permissive hypercarbia. Now, we have a lot of talks about how we ventilate the kids when we really need mechanical ventilation. Should we use pressure control or should we use volume control? or volume target ventilation. So let's look at some of the evidence for these two types of ventilation. In the early postnatal days, we advocate for volume target ventilation of about 4 to 6 ml per kilo of tidal volume to ensure adequate ventilation but avoid overventilation. Current data suggests that compared to pressure-limited ventilation, volume target ventilation decreased the incidence of deaths or BPD at 36 weeks of postmenstrual age, reduced the risk of pneumothorax, hypocarbia, and severe brain injury, and also days of mechanical ventilation. Unfortunately, very limited data exists for infants with evolving BPD. Recently, in a single-center retrospective analysis of 203 preterm infants who remain intubated beyond 14 days of life, the group from Texas Children's Hospital showed that the outcome of death before 36 weeks postmenstrual age, or BPD, is higher in those infants remained on pressure-limited ventilation at 21 and 28 days of life, as compared to those remained on volume guarantee ventilation. So this is limited data, but it's some efforts to trying to tease out what is the best way for us to ventilate those children. They found that each additional week of pressure-limited ventilation between days of life of 14 and 28 would significantly increase odds for BPD, or the composite outcome of BPD or death. In addition, those infants would have a much longer length of hospital stay. Give me a second, I need to plug in my computer. Okay. Now the third thing I want to talk about is the open lung concept. I'm sure many of you have heard of this concept. What we mean by open lung is to trying to open the collapsed lung fields and keep those fields open. And this pressure volume curve, many people are very familiar with. When we ventilate the lungs under the lower inflation points, or like under the lower inflation points, or over the higher the upper inflation points, you end up with atelectasis or overly extended lungs. The open lung strategy would improve compliance and minimize lung injury, but it needs adequate PIP or tidal volume, you said, so that you have high enough PIP, and also adequate PEEP to keep this open. However, some people only use high PIP or high enough tidal volume only, but they are afraid of give adequate PEEP. And when you do that, I do see that often. You would some people send me ask me how to ventilate a baby that are being difficult to manage, and I see the PIP is over 30 and the PEP is 5. And when you do that, when you don't give enough PEEP, you end up inflating, deflating, and this shear force is even more dangerous. And in those kind of lungs, you have both volume trauma and atelecta trauma in different areas of the lungs. In addition, some people only use PEEP, but they I can't say they only use PEEP, but they are not afraid of using PEEP, but they are afraid of the number of PIP. They say, oh, this is 25 weaker, the PIP is already 25, I cannot go up, but the lung is totally collapsed, right? So when you do that, you give enough PEEP, it may help improve FRC, but the lung compliance is not going to be better. and the CO2 would have CO2 retention. So to use the open lung strategy well, you need both adequate pressure to inflate and also adequate pressure to keep the lungs inflated, not totally collapsed. Another concept that we recently starting to introduce in the BPD collaborative is avoid air trapping. There are many consequences of air trapping, but what we talk the most is the generation of intrinsic PEEP and its consequences. During expiration time, when the baby cannot exhale fully, then you have air positive pressure retained in the lung and they're in the chest, and therefore the pressure, positive pressure in the chest gradually increase, and that comes as the intrinsic PEEP. With that, the intrathoracic pressure would increase, and when the baby trying to inhale, the baby would have to overcome the positive pressure in the chest first, and that's why the baby would take much more effort to inhale and able to trigger the ventilator, and the work of breathing would be much higher, and that usually would result in patient ventilator asynchrony, and the baby will get very agitated. So let me show you an example. Let's play this video first. You won't be able to see the ventilator at the same time. I often put my hand on the baby's chest, and I watch the ventilator flow curve. And you can see here, I put some arrows, black and red arrows here on the top picture. Those arrows, what they showed is that this baby is trying to breathe and the ventilator doesn't sense the baby is breathing in time. So have a very delayed triggering, okay? And this baby over time become very frustrated because in some of the breathing, he's trying to breathe, kind of breathe in, the ventilator doesn't know. And then when the ventilator kicks in, he's already done with breathing. And he wants to try to exhale, but the ventilator will not allow the baby to exhale. So a group of, in the BPD collaborative, the Indiana group, try to use a model, that a multidisciplinary team model, to look at babies with evolving BPD. So as soon they are over the first few days of early RDS, and they look at babies that at high risk for severe BPD. Those babies are in general born at less than 29 weeks of gestation, and they would have invasive mechanical ventilations for about a month at least. And they assess these babies at bedside with by their BPD team. And they look at the baby and they try to give the baby enough support by increasing tidal volume or PEEP, and until they give enough support that the baby become comfortable and doesn't need to breathe very fast. So the respiratory rate is less than 30 times per minute. And they would increase the inspiration time to ensure a full inhalation. And they increase PEEP until they see the patient can trigger the vent very well. So there's very good patient ventilator synchrony. Julie had just mentioned at the beginning of my talk that I ask for flow volume curve, pressure volume curve all the time. I also look at the flow time curve all the time. And I look at baby all the time. So each time assessing a baby, the needs for ventilation takes a long time. It frequently takes hours. But the goal here in the Indiana group, and also the same thing for me, is that we're trying to achieve adequate support so that the baby is comfortable breathing in and breathing out, so that we are avoiding air trapping. And by doing that, they have shown that these high-risk patients in their group have a significantly less chance of requiring tracheotomy over time once they kind of implemented this kind of ventilation strategy for those babies with evolving BPD. All right. Another part I want to mention is modes of ventilation. We all know that we have different modes that we can use: high frequency ventilation, we can use conventional ventilation, right? However, what is the best for these babies with evolving BPD? I would say I don't think there is a set answer for this. But when you look at the lungs, if the lung looks like it's ventilated unevenly, so there are areas of collapse, areas of hyperinflation, and that's what we talk about in the lungs of two-compartment model. The high-frequency ventilation has extremely short expiration time, and also active exhalation. It may create choke points in the small airways. These babies on high-frequency ventilation often have progressively worse air trapping. In addition, these infants generally have more sedation needs, and most units would not let the parents hold an infant on the oscillator. Both of these will contribute to the developmental delay of these infants with BPD. So once you have a lung with very obvious two-compartment model, we don't think high-frequency ventilation, it's going to be very helpful. It may, in a short time, decrease your FiO2, but decrease your PCO2, seems to ventilate better, but over time, a lot of times it ends up with air trapping. How about conventional vent? We use various conventional ventilation mode, and in this table, I put in the most common modes: IMVs, SMV, AC, and PSV. Unfortunately, each of them has their own characteristics, and none of these, there's a common problem here, but none of them would address the two-compartment model very well. So in a baby with a two-compartment model, generally in the BPD collaborative, we think an SMV with PSV model plus a managed volume guarantee would be the best mode to address the two-compartment model. So let's look at an example. Why is this baby considered so bad? This is a baby with kind of gradually worse lung disease and gradually increasing ventilator support. And by this time, you already required on the 6.5 ml per kilo of tidal volume per PEEP can be as high as 45. And because of FiO2 requirement is high, the unit gradually increased the PEEP to 12. The kid is already on FiO2 of 100%. When I saw this baby, she was on PCAC mode with volume guarantee, and the respiratory rate on the volume on the AC mode was set at 35, and tidal volume and TI set at 0.55. However, when you look at the baby, she was breathing 65 to 70 times per minute, and she could trigger the vent. And those are the flow time curves and volume flow curves that I just took a photo from the ventilator. The problem I'm seeing here is actually very common that I see when people use AC mode, both in China and elsewhere. They don't think about the backup. The rate on the AC mode is a backup mode. They actually set that rate very high. So, and then they don't set high enough of sensitivity, triggering sensitivity. When they think a baby is becoming a BPD kid, they think the baby needs a longer tidal volume, inspiration time. So they set the TI pretty long. But they forgot that when you set a rate that high, every breath is ventilated with the same fixed TI in an AC mode. So this baby end up with too long of inspiration time with a pause at the end of inspiration. And even when the baby wants to exhale, the ventilator would not allow the baby to exhale. So the baby become more and more agitated. And also she could not exhale fully because the rate is too high. Her exhalation would frequently get cut off. And in the end, the baby and the ventilator does not synchronize very well. And over time, the entrance PEEP would increase and she would trigger the vent harder and harder. And what we did here is to change from PCAC mode to SMV with pressure support and decrease the IMV rate, decrease the TI for this baby because I don't think he needs that long of a TI, and then gave her enough of the pressure support to kind of guaranteed her minute ventilation and her own respiration rate become lower. And you can see the change in her flow time curve and also the change in her loops. And she become comfortable. All right. Many people ask, when should I change from an RDS ventilation to a BPD ventilation? But I hope with my talk today, you already get this idea of these babies are not the same. Even for a baby with established BPD, they have different lung developmental stages. They have different timing and severity of lung injury. They have different ability and status of injury repair. So therefore, all these babies with established BPD have different lung pulmonary pathology and also mechanics. So I preach the idea of there's no single right ventilator strategy for BPD. And the ventilator setting needs to change over time and change even in the same baby over time or with different patients. So there's no set ventilator strategy for BPD. Then there's no set age, no set weight, no set ventilator strategies for a baby with evolving BPD. I think it all depends on lung pathophysiology and the lung mechanics. And you need to take your time to figure out what is the baby's status at that time and actually do a ventilator strategy accordingly. So in summary, ventilator strategy for evolving BPD, in my view, is both supportive and protective. So without supporting the lung to grow, you're not going to avoid BPD, right? The individual ventilator management need to kind of focus on individual babies' pathophysiology and pulmonary mechanics at the time you're trying to decide. And the goal of bicameral ventilation is to try to establish open lung volume, promote even ventilation, and also maintain the open airway. With that, the ultimate goal is supporting the baby's growth, lung injury repair, and also neurodevelopment. And that's all I want to talk about today. Julie already talked about Hippocrates in January. I want to say it again for the BPD conference in Guangzhou. We have the 2024 Guangzhou International BPD Forum, and I listed the international speakers here. And we have several phenomenal Chinese speakers too. And you can go onto Hippocrates website to register if you're outside of China. And inside China, we will post the sign up link in a later time. And also before this for international forum, we also have a specific session for BPD related respiratory research because this is such a hot area. And I'm so frustrated when I was the guest editor for the session of BPD session for Frontiers in Pediatrics last year and earlier this year. I was so frustrated there's not a whole lot of good studies. So hopefully this session will help people interested in respiratory research gain more skills, and you have the chance of interacting with all these great speakers and very experienced researchers in person. These are the list of some of my references that I mentioned in this talk. And thank you very much for listening. And I would be happy to answer some questions.
Thank you, Huayan. Wonderful talk as usual. And we are totally shameless in advertising for Hippocrates, right? We want every one of you guys to be there. All right, so Srini's got a question. Srini from our hospital. So way back when you were talking about acute RDS. So Srini, butt in if I'm not asking the right question. So he asked, when you mentioned a fast rate of 30 to 40, did you mean on a ventilatory mode of PCAC supporting every breath and not just 30 or 40 breaths from the baby, I presume, Srini, is that right?
Yeah, that's right, Julie.
Right.
Hi, Huayan. How are you?
Yeah, I think it can be both. It doesn't need to be said you have to be 30 to 40. I think whatever the baby is comfortable, the baby is okay, right? So if you're setting a PCAC mode, I often don't set the backup rate to 40. I set it as a minimum. I think it's a backup if the baby doesn't, like, especially for baby with apneas. And what I think will kind of guarantee a good minute ventilation. But other than that, I don't like to set the PCAC mode backup rate that high. So I often even go to 20. But for SMV with PSV support, you can start. We usually start setting the SMV rate at around 30. And then, or sometimes 25, between 25 to 30. And then you have pressure support breaths to support. And if the baby, it's not enough, we may go up on the SMV rate to maybe 40 or even higher as needed.
Okay. Thanks, Huayan. So Shipada from Perth has a 2 for the price of 1 question, right? So I think Perth is the only place in Australia that uses jet. I'm not sure. Melbourne will probably kill me. And he said, is there a role of jet ventilation in BPD? And do you use nebulized salbutamol?
Those are great questions. Honestly, we have tried jet for BPD kids. It works for some. That's why I would say there's no set strategies. You just have to figure out what your baby needs. So we actually had a baby, we used jet for a month. So he established BPD, but you just have to see. We kind of felt that for that baby, it may bring less of the lung injury for that baby. However, for a lot of babies with very severe BPD, it's hard for jet to really maintain a high enough PEEP. So when the baby has very severe airway malacia and I have babies need PEEP in the 20s to keep the airway open. Jet in general doesn't give you that. Then it doesn't work. So we have tried jet for some babies. It can be used in certain babies, but most of the severe BPD kids, it's hard to use jet. And inhaled steroids and bronchodilators, it's hard. We are struggling with how to give them, what's the dose of giving them. We know we lose a lot in the ventilator tubing. We don't know what's the effective dose. And also I see people just use them because they have BPD. But if they don't have small airway disease, I don't think there's much of a role in those, and then they soil the flow sensor and creates more problems. So I think it's, again, the medication use needs to be individualized. There are certainly babies who need those medications, and they are very effective, but most of the babies do not need that many of those medications.
Thank you. Oh, and wonderful to hear from Elizabeth Chong from Brunei. So Elizabeth, if you're feeling brave, you can unmask yourself. She's asking us a question that's always in our minds. how do you make us look at the baby and individualize the settings? This is the $1 million question, Elizabeth. So Huayan,
Really true. Yeah, I think everybody wants a cookbook. I would see then they don't need us anymore if we have cookbook, right? I preach for the art of medicine, and that's the clinical medicine that you need to spend time at the bedside. Unfortunately, the younger generations are not trained like that. I think what we need to do is we need to start training our younger generation to look at the babies again. I do have very phenomenal colleagues said in nowadays there's no need to examine the baby. I don't agree with that. And honestly, for me, adjusting the ventilator settings for a BPD kids, I often spend hours at the bedside. But that one setting may not work. I have pulmonary colleagues, a very phenomenal colleague, and came for like half an hour, do a setting and leave. And he doesn't know that baby didn't like it later on. The baby liked it at the moment, but doesn't like it later on. So you need to go back to the bed setting all the time, reevaluate. And there are a lot of tools nowadays. For example, like I showed, you can see I use the ventilator graphics a lot, right? We look at the synchronization a lot. So the individualized setting means that you can have all these tools. For babies, I suspect they're airway Malaysia, I may do a PEEP titration through a bronchoscopy. And when we do the bronch, we set a different PEEP and look at the airway, whether they're open or not, right? So there are different tools that you can use at the bedside to try to come up with the individual settings.
I think she's your person, Huayan, because she says that she sits on a stool at the bedside with her babies. Come to the BPD symposium, BPD conference, Elizabeth, and we can talk like individualized therapy. So we'll just run quickly through. You've got lots of questions, and these are the questions I always hassle you with WeChat about at like 10 p.m. at night, right? So from John from our unit, he asked if you can can you even up the lung? Is there a particular strategy? How do you get rid of this unequal overexpansion or underexpanded areas?
Yeah, that's a great question. But I think the first thing you need to do is to understand why they're not even. Right. So I mentioned the bronchoscopy at the bedside. I often find a very hyperinflated right middle lobe or right upper lobe. When you do bronchoscopy, you saw significant airway Malaysia in that area. Okay, so then we kind of try to ventilate to give adequate PEEP to keep that area open. But then you have some problem of the other areas you may overinflate. But you have to go somewhere in the middle. So I think it's for me is trying to understand why babies are like that, whether they have infection, whether they have secretion plugs, whether they have Malaysia, or they have small airway disease that they wheeze all the time. So then you can kind of tailor your strategy towards these pathophysiologies.
So that sort of leads on to Ken's question. Any clues from pulmonary graphics for airway Malaysia?
Yes. So for one thing I look for is synchronization. So when you have a lot of airway Malaysia and over time it creates intrinsic PEEP, baby become harder to trigger the vent. So whether we have what we call missed effort. So you see the baby is breathing, but when you don't see that on the ventilator, or you're seeing very delayed triggering on the ventilator. So you really have to count. I put my hands on the baby's chest and I watch the ventilator graphics. And I feel the baby is start to inhale, but the ventilator is not showing it. So that's what we call missed effort. That's one thing. And two, that's why Julia asked for the loops all the time. Okay. I look at the volume flow volume loop, and during expiration, your flow should come from at the beginning of expiration is 0, and then it goes to peak flow, and then go back to 0 at the end of expiration. So it should be a round curve. But if you have very quickly deflated loop, once you reach the peak expiration loop, it kind of concaves down quickly. That usually shows it's a large airway malacia, the large airway collapse. But if you're seeing at the very beginning of expiration, that will become flat. That's usually a small airway problem, because when you think about the flow pattern, when you exhale, the air comes out first from the large airway and then the small airway, right? So you can get some flow from the flow volume curve loops. Okay.
Wow, I think we could go on for like 3 hours with questions. They're just flying in. But if you really want to get Huayan to answer your questions, again, come to Bali and Guangzhou. We'll make sure you get fed well, but we might take a couple of last ones if that's okay. It's a few minutes past the hour now. Just a group together with PSV and PEEP. So PSV from Apan in Singapore and PEEP from Tim in Canberra. Apan is asking, what's the number you use for pressure support? And Tim saying, would you use higher PEEP in the first few weeks to avoid ectolectal trauma?
Okay, so I think there's usually not a set PEEP at the very beginning. We mostly use people 5 to start, 5 to 6 to start, because I don't really think lower than that you have adequate support to keep the lung open. The smaller the baby, the more premature their chest compliance it's better. It's easier for them to collapse their lungs. So you really need to keep that FRC, and I think you need to start at least a 5 to 6 of PEEP. And then whether that PEEP is enough, then you look at the baby and look at the x-rays. And now we have lung ultrasound. You may be able to help look at atelectasis, right? In terms of pressure support breaths, in the early days of RDS, we generally use a pressure support that achieve slightly lower overall pressure or overall tidal volume than the SMV breaths, because you don't want to give too much of support and you want them to come off ventilation as soon as they can, right? So we can use that strategy initially, but if they don't do well, we adjust. For BPD kids though, the whole goal is support. I'm not in a rush to extubate anybody. The whole goal is support, and I want to support their spontaneous breathing. So we actually aim to give higher pressure support, very similar to what you are achieving in the SMV breaths. Very similar, but we come all the way down of the IMV rate over time. So that's why we set the low rate strategy. It's more meant for the IMV breaths, right? And then once you come down the overall, it's like lower settings, you come down on your pressure support before you extubate. But when they're old, we can actually extubate from fairly high pressure support. So no set number, but we look at what you need in their SMV mode, in those breaths.
Okay. Thank you so much, Huayan. I think we've got to call it a day now. Wonderful talk and lots of questions that people can get answered when they go to Bali and Guangzhou, right?
Yes, absolutely. I would love to chat.
Yes, I know. BPD for like 6 days. Woo. And I've also put in the website for the BPD collaborative if anyone wants to join. I think for a fee, of course, but there is so much knowledge exchange possible in that group, right? Yeah.
Yes, absolutely. It's such a rich group.
Yes.
And we are the groups that are dealing with the most severe BPD kids around mostly in the United States, but nowadays, gradually, there are more international groups joining. And we're trying to push out more research and also case discussions. There's one case discussions once a month on a Monday afternoon. So it's a very rich resource, and people chat all the time and talk about things.
That's great. And Dr. Rathmoni, I think from, is it Cambodia or Laos, has asked if she could have the slides. If you have time, send me the PDF and I'll share it with this group. That'd be wonderful. Cambodia, thank you. Okay, and
Okay.
Elizabeth will see us in Bali. Wonderful.
Great,
Okay.
wonderful.
Okay, thank you so much, Huayan.
All
Have a
right.
great
Thank
day.
you.
Thanks, everyone.
Thank you,
All right.
everyone.
Bye.
Bye.
Recording